Today we have Dr. Michael Reed, OBGYN, specializing now in cosmetic gynecology, really just a vagina doctor like me. We share a lot of similar ideas and really similar concerns about women's healthcare and the neglect thereof. So you'll see two of us and Karen, of course, with us, seeing what we can do about this problem. We have the answers, but we need more people. And as Dr. Reed would say, we need more gladiators. Enjoy it. But what do I know? I'm just a vagina doctor. So, Dr. Michael Reed, welcome to the Vagina Doctor podcast. It's great to have you with us today.
Well, thank you so much. It's an honor and a pleasure to be here.
So you went to medical school, Creighton University in Omaha. You did a residency in Michigan State. And that, I'm sort of guessing that was about 20 years ago that you did your residency.
About right. A little longer than 20.
Okay. And you've been specializing in cosmetic gynecology for the last 10 years. Is that about right?
Yep.
So like myself, you're a vagina doctor also.
And, I agree. I love that title, by the way.
I'm glad you like it. Some people are
a little hesitant, but we wanted to make a statement because this is something that needs to be talked about, and it's not. And you're actually the third guest. We had Peter Castillo, who's a urogyn in the Bay Area. I've worked with him over the last few years, and then Red, of course, who I've known for decades, and we've worked together on certain things, and all of us have the same concern. From my conversation with you, and learning about your practice, looking at your website, looking at what you're doing, we share these concerns that, as you put it, women's healthcare has been left behind.
Yeah.
And my statement to that is it's always been behind. They've never been equal. Okay. They've never been given the attention that they deserved and they needed. And there are a few of us around, and I think increasing number, who have looked at that and said, this isn't right. This isn't good enough. Look at all the things that we can do to help. And it's, and I look at OBGYN generally as a happy specialty. Okay. It was fun to deliver babies, and except in the middle of the night when you really would rather be sleeping. But you had good results, and, tragedies occurred, but they weren't very common. So, and people just stop me on the street now and introduce me to their, maybe their 40-year-old child that I delivered. It's going back. And then when I stopped doing OB, for a while it became just general gynecology, and it wasn't that interesting. But then as things happened and there was more science involved with it, and all these things that we could do to help women through menopause, a lot to the extent for the help of the North American Menopause Society, that where there was more that we could do. And it's with those things that we're doing now, we've actually got happy patients again. So it's become the happy specialty again. So what happened to you? Why did you go from the change of general OBGYN to cosmetic gynecology?
That is an excellent question. I mean, my journey was born really just out of, I just couldn't believe that I would deliver babies, 5,000 of them, have a large, thriving practice, and then one day you're drained for some reason. You just don't have that passion. It's like everything was born out of burnout. Mm-hmm. And so I did look within the organization to figure out how can I improve this feeling that I'm having, that this is what brought me through medicine. This is what I'm sure kept you up at night, to learn the information, to be able to help patients, and then been doing it for so long and caring for so many people in the community of Omaha, Nebraska, to then wake up and say, oh, it was painful. And so I had to find a way to try to pivot and figure out a way, how can I bring my passion back? Because I love caring for women. I love the ability that brings, the intimacy that it brings, both delivering babies and helping on the other end of aspects of keeping relationships together and happiness. And so anyway, I looked to learn more about cosmetic gynecology. I found Dr. Matlock, and then I found Michael Goodman. Michael Goodman is one of the pioneers in female cosmetic surgery. He wrote the first textbook in female cosmetic surgery. But more importantly, I feel like he kind of bridged cosmetic gynecology with academia in a way, because he's published at least 10 scientific papers that were well written and very supportive of the ideas and fundamentals that we believe as cosmetic gynecologists. And so I was lucky enough to have this opportunity, and I trained with him for 18 months. As it stands as of today, I'm probably the most trained physician in the entire world. I can for sure say that in the United States. Mm-hmm. And it's just hard work, commitment to be able to do that. And so this transition to going from general OBGYN to now cosmetic gynecologist was a simple transition. It was hard to do, but it has been so rewarding in so many ways, that I'm happy with the decision. I like to say that I have experienced the vulva from not only the past, when I used to deliver babies and care for women who needed contraception, to caring for women now who want to improve their own sexual intimacy. And I'm also the doctor who understands the future of the vulva in terms of we need to catch up the modern day woman when it comes to their sexual intimacy. Mm-hmm. And I think that's how I got started. Gives you a little feel for the passion that I have for this.
Indeed.
And I am here so that we can get more physicians that are listening to this to say, I feel the same way. I feel things are lacking, and I want to be a part of this as well. So how do I get on board? That's what my goal is at the end of this. Because then we'll change the landscape for women, because it can't be done by one person. It's got to be done by all of us.
Absolutely.
But let me stop. That was one question. I'll stop.
No, okay. I think I like that you say that it can't be done by one person. It is. Yeah,
it takes a number of people. It takes women, it takes men, it takes relationships, it takes physicians, it takes ACOG, the American College of Obstetrics and Gynecology, to say this is important to us and women are important to us. They haven't done it yet, but we're going to get them there.
And
You're persuasive.
Yeah. So what are you actively doing to help get them there? What is being done?
The first thing we have to do is, one, we have to let ACOG know that women have an extreme desire to change their overall sexual intimacy. They want more, just like men did.
Yeah.
And we still do, right? Long time ago, if not too long ago, decade ago, we had testosterone clinics everywhere. We got Viagra everywhere. Men can say, yep, I got ED. Yep, I got Peyronie's disease. Look how comfortable men have gotten. Mm-hmm. Well, we need to equalize that for women as well.
Yeah.
And so what I'm going to begin with is, one, educating, like your platform, getting the word out that somebody and a group of physicians called cosmetic gynecologists are out there to help women to improve their sexual intimacy. So one is repeating the knowledge and repeating the positive things that come with developing a specialty such as cosmetic gynecology. So then the second thing that I've done is I started an institute called the Institute of Restorative and Cosmetic Gynecology. The whole idea behind that is we don't get any of this training in residence. Zero.
Right.
I don't have all the skills that I've acquired at this point have been due to my own unwavering commitment to educating myself, to being exposed to wonderful physicians like Michael Goodman, as well as Red Allensod, and others like Dr. Peter Attia. I mean, not Peter Attia, down
Peter
at
Castillo.
Swan, Castillo, and listening to his. I mean, we're out there. We just need people to know we're out there.
Right.
Right. And it's going to change because women want this. All of us have busy offices, not because we're doing quack stuff, not that we're making up stuff. What we're doing is we're listening. See those elephant ears popped out? We are listening to our patients. That's what we're doing differently.
So 2 points.
Yes.
One of them is that when the Mona Lisa CO2 laser equipment was delivered to the U.S. 2015, 16. I got one fairly early in that time period, and the reason why, I mean, first thing I heard about it, vagina in the laser in the vagina, that doesn't make any sense to me. But then I saw some histology, some slides of before and after histological proof that, wait a minute, this really changed. This has got to work. And then it was then beginning to try to talk to patients about it. And that required, and I think I said to you on the phone, it changed. I changed my new patient paperwork. Do they have any issues with intercourse? Any pain with intercourse? I mean, we didn't talk about that as a gynecologist previously, or at least I didn't much. It got sort of a little weird for
today.
Yeah. Okay.
Karen, do you? I mean, besides your husband, Karen, has your last visit? Did they say how wonderful has intercourse been good?
No.
Have you had problems with this or that? And how can we improve your sexual wellness? And yes, we need to schedule your mammogram and pap smear, and
right.
And that's
no one brings up anything about that ever. Yeah.
So I felt like, okay, we'll start this conversation. And honestly, the podcast is an extension of what I went to, 8 years ago, and what we've come through. And so this is to get the word out. The second problem that we've had is our colleagues, our general OBGYN colleagues, don't really appreciate what we're doing. They're not supportive. At least in my experience, they're not supportive. They do think, I mean, and even a lot of the literature that comes out is not very, encouraging in terms of the technologies that we're using. But we see this. And when you can see slide differences, histological proof of changes, and it gets through. The fact that we can use any of these, radiofrequency or laser, for lichen sclerosis. I mean, suddenly I see a lot more patients with lichen sclerosis now because we talk about it on the website. I never thought there was that much to it. In fact, to everybody else, the only thing you could ever use is clobetasol. And
exactly.
And now we have things that really work. So that's why those are two problems that we've had. Patients not being talked to about it. Nobody was listening. And secondly, we don't have support from our colleagues, which, as you put in terms of ACOG, and I put in terms of my colleagues here in Santa Barbara. But going back a moment to this, the female patient being left behind, why do you think that happened? Is it because most OBGYNs in the past were male? And all they were doing was, well, actually, they were doing deliveries when they needed to, and they were doing surgery later on. And is there a difference now that most OBGYNs coming out of residency are women? Is that changing things? And I would argue that it's not. I don't think the female OBGYNs coming out of residency are any more in favor of what we're doing now than our other male colleagues who have been around longer. I don't know what your experience is with that.
I agree. I've talked to, and they go, why would I want to learn how to do that? I actually did, graduate from Creighton. I did a grand rounds at Creighton University talking about just the general things about female cosmetic surgery and all the different functional and cosmetic things that we can do.
Right.
And they were like, well, why am I going to learn that?
Yeah.
Well, so that's what we're going to have to do. So we're going to have to, in a sense, if ACOG isn't going to get on, we're going to have to do like Big Pharma, right? Big Pharma went to direct marketing to the patient, right or wrong, and they bypassed the physician. And so the Big Pharma said, Karen, this is the medication you should use. This will change your life, right?
Yeah.
And you say, wow, that really will change my life. Maybe it will. Then you go over to your doctor, Duncan, I want this medication. And then you go, well, I don't know much about that medication, but I'll get back to you. And now if we can do that over and over, now the guys and the gals that aren't listening, they better listen or they're not going to have patients to care for them, right? So we got to, if ACOG won't get on, then we'll bypass ACOG as of now, not forever, because we need them. We love them. We want them. But if we have to do that to get the pressure, then we'll bypass ACOG and directly market to the patient and then have the patient do the work for us.
Okay. And I think that's where podcasts come in.
Yes,
one of the ways of doing this, because there are, I mean, when we first started using Mona Lisa, and we tried to do some marketing on the radio, we couldn't say vagina on the radio. We couldn't.
You still can't do it on Instagram and stuff. They shadow ban.
Right. It's true.
And that's so archaic, but it's the reality. And so we're using anything we can. So good for you that you've got a system in place for training people to do it and training physicians to do it, and are supportive to the whole concept. I mean, you get the problem. We're speaking the same language.
Yeah, so we're preaching to the choir, as they would say, huh?
As they would say. Yeah.
Well, we get so many patients that are with their female GYN in town, OBGYN, that won't go there with them on these topics. So they end up calling Duncan for consultation because they want, hormone replacement therapy, sexual health. And they, when they call, they're actually really frustrated because they've been in a frustrating process. So,
I mean, sexual desire is the most innate human need. Not a want, it's a need. Look at all the wonderful things that come out of sexual desire and having that close intimacy with someone. So it's not a want, it's a need.
Yeah.
Men have been, we need to equalize this for women. So just because you're a man, you have a need, and a woman doesn't have a need? No, that's BS.
Yeah.
We both have a need. It's a human need, innate human need.
Yeah.
Absolutely. Anyway, go ahead.
No, I love your enthusiasm and your passion with this topic.
Yeah. We're going to change it. This is not if we're going to. No, it's about when.
Yes.
We are going to change it.
Yeah.
It undoubtedly. I have no doubt. No doubt it's going to change.
So what more can we do? Or let's actually be a little more specific. What your Institute of Restorative and Cosmetic Gynecology.
Yeah.
What are you offering there to the physicians? What's that all about? Tell me about it.
All right. So what I'm offering to the physician isn't just a training course. This is going to become a tool. I like to think of it more like gladiator training, in my opinion. It's gladiator training. And to be a good gladiator, you need to learn a whole bunch of stuff. So I have Carolyn DeLucia. She is by far the queen. She knows everything when it comes to non-invasive procedures. She has all the non-invasive procedures. She speaks all over the world, just as I have. She speaks for a lot of the big laser companies, and we have partnered on this. So it's not just me. Carolyn DeLucia is with us. She's an amazing speaker and individual. So you'll get non-invasive treatment. I'll spend a lot of time on surgical treatment. The thing that we'll both collaborate on is how to transition. I did the transition. I went from traditional OB, lucrative practice, to now cosmetic gynecology. I've been trained for 18 months. I have a good idea of everything that I feel that a resident should have and have trained under. So having said that, we'll talk about different things that I feel are important to have in your office. So when you open an office, just like when you go to gladiator training, you're given a shield and a sword and a manual. Well, you need to have sonoquents, because if you're going to do any kind of surgery, you want to be very refined. You want to be able to have like Thermiva or a laser of some sort, one or two.
Mm-hmm.
So we want to make sure you're educated on those things. And then finally, you want to be good surgically, right? So I have cadaver lab.
Mm-hmm.
And so the first time that you are going to the physicians that are working on patients won't be their first time, because they'll have worked on a cadaver lab. I'll be right next to them.
Yeah.
Classes are small. Carolyn will be there. So you can't get any better than that as far as
Right.
hands-on.
Mm-hmm.
And then we extend and be available.
Mm-hmm.
So she can send me pictures. She can call me. She can ask me questions. We just try to reduplicate this, and then reduplicate and reduplicate. And then finally, ACOG is going to get on, because the physicians that are training to be gladiators will then begin to hear all the noise in the background of women saying, we need help, we need help, we need help. And they'll hear it, and the chants will get louder. The more physicians will get on board, and it's done. It's done.
So let's go back to the doc that you mentioned earlier, David Matlock.
Oh, David, he's a wonderful guy. I have not met him yet.
Mm-hmm.
I have not met him yet. I have studied him.
Yeah.
But I haven't met him. Yeah.
So I haven't met him either.
Mm-hmm.
I've heard him. I've seen videos and so on. And for those that are listening to us, David Matlock was the first OBGYN to call something cosmetic gynecology, to create the term. I mean, frankly, we were doing a lot of those operations anyway.
He did more than create the term. I think that's part of it. So when he came on board, there were most of the labiaplasties and those kind of things that were done on pediatric patients that had extremely large labia, where there's just no question. And so they were doing the trim technique. And what would happen is a lot of people had a lot of edge sensitivity and chronic pain. So whatever he did, he figured out a way to get rid of this edge sensitivity, and he began teaching that. The other thing is he took the traditional anterior and posterior repair and made some non-intuitive changes to the anterior and posterior repair, and made them such that they would improve sexual gratification. And he did that. And he was well ahead of his time. Mm-hmm. He was an excellent listener, because he was able to come up with these changes by listening, because he didn't have a vagina. So the only way he could understand was to listen. And so in my opinion, I think he's, the GOAT. I think he, really did a lot of wonderful things for the women. I also feel that he was ahead of his time. And in that, if I were to ask you, Duncan, if I came up with the cure for HIV, I would expect to be paid. Would I be inappropriate to say that in 2024?
No, you would be right. You'd be correct.
I would be right. But in 1996, when all of this started, no, you could not ask for money. David Matlock did. He at the same time was doing his MBA. Now, all of this is secondhand. I have not talked to him. This is me reading and studying him and looking at him and all that. So he had also got an MBA at this time. He was also getting his MBA. And so he knew the power of intellectual knowledge. And he said, okay, if you want to know how to do this, I've sat up in the middle of the night. I'm the one waking up at 2 a.m, writing stuff on paper and trying to figure out all this stuff. Well, I want to get paid for it. And that was a turnoff in 1996 to physicians. ACOG, I'm sure there were some leaders in ACOG that said, man, this guy's down here killing, he's doing something. Let me go down here. I'm sure he'll teach me. I'm the president of ACOG. I'm sure he'll teach me. And he goes, yes, absolutely, I'll teach you, but it's going to cost you. And he didn't like that. That president probably didn't like that.
Okay, so but was he getting paid? So he was getting paid for it? Is that?
Yeah.
Okay.
Yeah, of course you get paid for training, right?
Yeah.
I
Yeah.
get paid for training
Yeah.
physicians.
No,
Right.
I get that.
Yeah, yeah. So he did it in 96. He just did it 25 years too sooner. But he also was the one that changed that concept for us now. And because of, go ahead.
Yeah, I was going to just say that I think that he's probably a very good surgeon, but his success came from his MBA, in my mind. He worked out how that makes sense, that he had procedures that could be done. And just as you've said, yes, I want to be paid for it, because that was the turning point. And there are people all over the world that have been trained by David Matlock, literally all over the world.
Yeah.
But it was that brilliant business plan that got him there. So it's really, I mean, he did coin the term
designer vaginal rejuvenation.
What was it?
Designer vagina. And laser vaginal rejuvenation. And I mean, you're using radio frequency instead of laser.
Yeah.
I'm making that assumption because what we've talked about. Yeah. And that's just an energy device. There was nothing magical about the laser that caused this to happen, but it sounded like it. And it's almost like, now I'll sort of throw another tangent in here a little bit of how things get misinterpreted by patients. But let's take robotic surgery. And the general OBGYN doing straight stick laparoscopy doesn't do very much of it. And it was only when the robot became available in 2006 that they had access to that. And then they found it easier to do laparoscopic hysterectomies. And the only reason that they could do that better was because the robot made it easier to put in a stitch and tie a knot. But it changed things. It changed things positively in lots of ways, because it now more women were getting minimally invasive surgeries than the major surgeries. And that was really a benefit. Unfortunately, the industry again caused or enabled physicians to take shortcuts. And so a lot of the people that are doing the robotic surgery actually can't do a straight stick laparoscopic hysterectomy. And so it's really been, it sounds to the public that, oh, my surgeon used the robot and that must be good because it's sexy and it's high tech. And the laser in the cosmetic fields a decade before did the same thing, because everybody was thinking, oh, I want a laser repair to the vagina because that's what is supposed to be the best. It really wasn't, because as you're finding, you're using the best equipment available to do radio frequency surgical procedures. So those things don't get very far, or they don't accurately get further, because you're doing everything as good as or better than he was doing by using different equipment. And so it doesn't need you to be called a robotic surgeon or a laser user or doing laser vaginal rejuvenation. But it did start a wave, and it was, you talk about going beyond ACOG to do what we're trying to do, and that was actually what David Matlock was doing was to the patients. He was presenting something that it was patients looking for those procedures. The designer vagina. That's what gave him his name. And so it was going around and about, avoiding the other OBGYNs who thought what he was doing was not appropriate, or the college not being willing to take on any cosmetic stuff. So it's really, there is this point of having to go to the consumer that we have to promote. That's a lot. That's a simple answer. What I said, used a lot of words for it. It's the same thing.
It's wonderful.
Well, yeah,
So-
but when I hear designer vagina, I just instantly think a surgical procedure,
Yeah.
right?
Right.
And that's what it was.
Yeah.
Yeah.
Yes. It is, and but it's letting. I mean, I do the procedures that we've been talking about surgically, but I don't do them nearly as much now as I used to because of technology. Using radio frequency, using laser vaginally, whether it's a CO2 laser or it's microneedling, they're all working well, and they're working, very, very well for a lot of patients. And there's no downtime and so on with them. So yes, we still do. I don't have a substitute for a non-surgical labiaplasty. I mean, I haven't seen anything that kind of works.
I know
well
there's
for
things.
that.
I agree.
Yeah. I mean, we have one technology in the office, the Aviva, right?
Yeah, it's part of the Empower.
Yeah. And it just hasn't really. Yeah. What are your thoughts on that?
Yeah, I mean, I love the Inmo company and everything, but I think that the Aviva Tight is you get very modest, if any improvement, not significant enough that I would feel comfortable bringing that into my office and say, this will work for you, this will change, because I just couldn't do it.
Right. And I mean, I have it in the office, but it's part of this whole platform of InMode of radio frequency with microneedling.
Right.
Which is
I'm just talking about the labiaplasty part.
Exactly.
Everything else is, yeah. But I'm just talking about the labiaplasty.
Yeah, I mean,
only.
it's a nice idea if it worked, but typically those patients come back and do surgery because they're not happy with the result.
Right.
So,
but we've got lots of good tools these days, and we're just it's fun.
But see, that's the other reason. That's the other reason why we have to get academia on, right? Here's the other reason, in my opinion, is that we're always fearful that something is snake oil, right? We're always fearful that we're charlatans or quacks, right?
Right.
Because we're doing different and new things.
Yeah.
So if we had a actual discipline that we fell under, then we could we can get some studies done, and we could say, is it PRP or is it the fractionated CO2?
Yeah.
Well, in the office, I know if I combine those two, woo, it's amazing. But do I really know which one it is? But if we had academia with us, then we could run a good randomized controlled trial study and say, let's do PRP, let's do fractionated in the second group, and in the third group, let's do A and B. And then you could maybe determine that, you know what, it's not the fractionated CO2, it's the PRP. And then now you eliminate a cost that's not really doing anything.
Right.
But we found out what really is.
Yeah.
And now we can further legitimize it, further study it, and then say, PRP has been around 50 years, and these are all the randomized control studies. These are the standards. It's a standard of care now.
Yeah.
That's how everything starts.
Yeah.
So that's my 2 cents on that.
I have a question about, one of the things that I think that we struggle with some patients in the office is what works best for filling. Duncan calls it the wing
lift.
The wing lift. But we have patients that absorb product quickly, and it's frustrating because they spend money and then we're going at it from different angles. But do you have anything that you do that you can chat about?
Red has recently made available a mixture of hyaluronic acid and PRP.
Yeah, Femexa.
Yeah, right. And I've done the wing lifts for a long time with straight PRP, and I've been pretty happy with it. And I did one patient recently with the hyaluronic acid as well, and it actually was it lasted less time.
Well, it lasted 5 days.
So
5 days.
So It's not gonna. So it's the so the how the I use the hyaluronic acid in the PRP.
Mm-hmm.
The hyaluronic acid is like a highway. It's your pathway.
Mm-hmm.
And then the PRP is going to act to stimulate the fat cells, right? So you want to stimulate the fat cells in a way that will be both aesthetic for the patient, right?
Yeah.
So you mix the two, and the patient has to understand this. You're going to look wonderful. It's going to be plumpy and plump, but then it's going to reabsorb, and you're going to look flat for a little bit, but then it'll start to plump back up.
I agree
and
with
it
you
always
completely.
does. So if she knows that beforehand and understands that the hyaluronic acid is there to kind of show the PRP where to go and what fat cells to stimulate and how we want it to look, and that you'll have a little bit of fluffiness from the hyaluronic acid that'll still be there to give you a little volume. But in the next several weeks, when the PRP starts stimulating the fat cells, it'll know exactly where to go. And it will plump back up. It always does. It will plump back up.
I
and
agree with you. I
It
just
goes down around 3 or 4 days.
Yeah.
Yes.
I think this patient had exactly what you say. It was that initial reaction, then the fluid gets absorbed, and so what was there for the first few days goes away. And so my encouragement to her is wait. You're going to get a response. So
yeah, and the other thing that is nice if you're trying to do, I call it an energized vampire wing lift.
Mm-hmm.
So I'll use my Thermiva first, and skin tighten first, the skin, and then I'll do my Femexa underneath.
Mm-hmm.
So now you're going to get a little bit of skin tightening that they're going to see right away. That isn't going to go away right away.
Right.
And then when it begins to deflate a little bit, you still have a little bit of tightness because you have your Thermiva effect.
Right.
And then in 3 weeks, you're going to get tightness from your Thermiva. And also around that time, you should start to see fat cells responding to your PRP.
Right.
And then you're bringing her back in to retighten the skin again right around that same time. And so I think that's the way you want to kind of layer it and explain it so that the patient understands what's going to happen, and you're optimizing the look that she's trying to attain.
Yeah.
Are you using any devices for pleasure, like the shockwave therapy or?
Yeah. So for strictly pleasure, I think the Duo low intensity shockwave therapy is an amazing machine. That's the next machine I would like to get. Maybe Alma can give it to us for free. Shout out. No, I'm just kidding. But the other one is, have you heard of the Vagina? This is I think of it as a tool, and it just creates kind of a ramp for the penis to penis, finger, or toy to push more right into the anterior vaginal wall.
I've read about it.
And that is all strictly for sexual gratification or pleasure. There's no functional things that are improved. It's you do get a little sense of tighter minimal surgical tightening.
Yeah.
But it's mainly there to act as a ramp and act as a guide for the penis, finger, or toy to hit the sweet spot.
Okay, but what is it? What is it? Explain what it is.
It's a surgical procedure.
Okay, it's a procedure.
Yeah. But you're doing it under local, presumably, are you? Are you doing it under local? Are you doing it under local anesthesia or general?
Yeah, every patient that I operate on is on local anesthesia. If they have a vaginoplasty, they're awake.
Yeah.
If they have vaginoplasty, labiaplasty plus labia majoroplasty with the anal skin tag removal, it's all done under local anesthesia.
Right.
So everything's done under local. Okay. Long answer.
Yeah.
No, so short answer would be yes.
It's a surgical procedure. And what exactly are you doing in that surgical procedure?
Well, see, the Vagina is trademarked, Karen.
Oh, okay.
It's trademarked for a reason. So, I mean, I can't tell you.
Okay.
You can get training. Marashi will definitely train you.
I'm just curious.
I will explain to her afterwards.
But, I mean, I can't explain any more than it's going to be a ramp that's going to hit that anterior vaginal wall.
Okay.
I can tell you, as a OBGYN, and you do these surgeries, it will be very simple for you to understand very simple for you to perform, and we're the right group to take care of this.
Okay, and so what are you doing most right now? If you had, I mean, is it surgical or is it non-surgical?
Well, this is what I do. When a patient comes in to see me, I tell them, I say, listen, I can do a whole lot of things, a whole bunch of things. It's not me that determines what needs to be done.
Mm-hmm.
You're the wearer. Understand that you have a gladiator that will kick ass. So what I really want to understand is, what is bothering you? What is it that you want to improve upon? And let's be specific. If we can more specific we can be, the more likely we're going to be successful. So tell me what it is that you want to accomplish. And if it's a non-invasive procedure, boom, I'll take care of that. If it's a surgical procedure, I'll take care of that. One patient this morning wanted a vaginoplasty. She thought she did, but that wasn't the right operation
so
for
much
her.
Of the time
we talked about, and the procedure we ended up doing is the Vangangelo that we talked about, because she was here to get a little bit tightness and to increase her sexual gratification. So to answer your question, short answer, I put my little Dumbo ears on and I say, how can I help you? How can I make things better? And whatever that is, that's what I'm going to do.
Yeah.
That's great. I love it.
That's the plan. Whatever they want. Just tell me what to do. We'll do it for you.
Yeah. What you want. But that comes with training. It comes with confidence. It comes with an unwavering commitment to read and read and read. Mm-hmm. It comes with being able to talk to patients, to work on talking, get in front of the camera. I didn't talk like this 4 or 5 years ago. I was scared to talk.
Yeah.
But working at it and wanting it and being that voice for so many unspoken women, I had to change. I had to pivot. So here I am. Thank you, Duncan, for allowing me to be here.
Well,
but I have a couple more questions.
I have another question though. What do you think about combining like the shockwave therapy with PRP and Thermiva? Because I've been reading about people combining those three.
Yeah, that's wonderful. There's no reason not to combine biologics with energy.
Mm-hmm.
Right.
None whatsoever. Works wonderful. The only thing you have to remember is always do the energy first, followed by the biologic.
Oh, of course.
Because the biologic is usually just a string of proteins. And so if you add heat, like Thermiva, or if you add laser, which evaporates the water, creating heat, you're going to shatter your peptide chain or your PRP. So always do the energy first, followed by the biologic. But combining those two, synergistic.
That's what we found too. So a couple of things on a personal nature. You enjoy cooking.
Yeah.
You enjoy football. Was that playing or watching?
No, so football, I only played up until high school. So I enjoy really watching it. I'm a Raiders fan. I think when I went.
Oh, no. End of conversation. End of conversation. End of
conversation.
Oh, okay. That's okay. My
wrong team. Silver and black.
But the other thing that I noticed in that, boxing. So
yes, I love boxing.
Yeah.
The boxing. The reason why I like boxing is that the only way you can really be good at it is you have to believe in yourself, because there's nobody else there to do it for you.
Right.
You don't have a teammate to lean on when you're not feeling good or not feeling it. It all has to be you. So you have to have this unmistakable belief in who you are to be able to accomplish and compete in this field. And so I think that's what I like about is that strong belief that you can win, claiming it before you even start, and working towards that goal. You're also changing as a person too. So there's like that's I love boxing for those reasons.
Me too. Agree with you completely. We did agree on a lot, for sure. But thank you very much for spending some time with us today. And we're going to, we'll continue the fight. We keep
let's stay in touch. Yeah.
Please, let's do it. I mean, that's all we're trying to do. We can get a few more gladiators on board.
Yeah.
And take it over.
That's
we're taking it over. We're going to change. Landscape is going to change, undoubtedly, step by step.
Okay. Thank you. Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.